guys, and welcome to week 3. We're going to be touching on patient assessment. This is week 5 of the course. So, what is assessment, or why is assessment important? This is what provides the basis for effective cancer care. When you can assess what's going on with your patient, you can create a plan or a means of treating that patient effectively. We obtain information as providers in order to know how to address the problems that the patient has and how to care for them appropriately. So assessment allows us to determine the nature of the problem, select an intervention for that problem, and then determine if that intervention worked. And if it did, great. And if it didn't, then we have to kind of go back to the drawing board and figure out how we're going to fix this problem. We're not just going to let the patient go home with something that can be taken care of. So we have something called the therapeutic relationship, and this is kind of like the relationship between the therapist and the patient, where we're working together towards making this a beneficial experience for the patient. The way your book defines it, it's where the therapist and the patient hope to engage with each other and affect beneficial change in the patient. So and then what kind of forms that therapeutic relationship? We have verbal and nonverbal communication. We have the therapist has to have communication skills where we hear the verbal messages, we perceive the nonverbal messages, and we respond with verbal and nonverbal messages accordingly. And finally, we have to be effective listeners to communicate with the patient successfully. So that's kind of where we use the skills of reflective listening. We're going to touch base on that in future slides. So what is verbal and nonverbal communication? So some say that 2/3 of communication is nonverbal. And although verbal messages are much clearer than nonverbal, nonverbal seems to come, it encompasses the majority of the communication that is going on. Verbal messages are composed of cognitive and affective content. So cognitive is facts and words, and affectives is kind of more about feelings, attitudes, and behaviors. So affective communication is where you involve emotions such as anger, sadness, fear, and happiness. The radiation therapist needs to listen reflectively to the patient and identify what the patient is feeling. So when we're talking about reflective listening, it's where you are reflecting essentially what the patient is saying in order to show them that you understood what they're saying. So whatever the patient is implying to you, you kind of gonna reflect it back to them or spew it out back at them to make sure that the message was understood. And we're not talking about just things that the patient might say, oh, I'm feeling fine. But if they're cringing, if they're wincing, if they're groaning, then you're going to interpret that and you're going to say, hey, I know you said you're feeling fine, but it seems like you're in pain. How can I help you? Or let me know how I can help you in order to get through this treatment. Things like that. It means you're responding with empathy. And empathy is when you identify with the other person's feelings. So whatever that other person is going through, you're able to notice it and you're able to take it into consideration. So the 10 most commonly used verbal responses. So your book goes into the 10, which is first, it's the minimal verbal responses. Yes, I see. That's kind of when the patient is telling you something, you need to respond verbally to them with yes, oh, interesting, okay, and then what? Kind of like that. You're giving them that reassurance that you're listening, first of all. Reflecting, so that's kind of what we just said. You're reflecting the understanding. You're letting the patient know that what they just told you, you're going to show it back to them and make sure that that's what they meant to say. Paraphrasing, so if the patient says, I'm feeling fine, you can say, oh, I'm really glad to hear that you're doing well. There you go. You paraphrase the same significance. Why are you paraphrasing or why are you reflecting? Because you want to show understanding. Same goes with the minimal responses. You want to show understanding and that the patient is saying something to you and you're receiving it. Probing, that's kind of where you use open-ended questions. So I think I used one of those for the minimal verbal responses, but it's kind of like, oh, is that so? Or how did that go? Oh, I had a chemo infusion earlier today. How did that go? Probing. Clarifying, you're using it to obtain more information. So if the patient said, oh, my appointment didn't go well yesterday, oh, what happened during your infusion that didn't go well yesterday? Just clarifying. Interpreting, so we add something to the patient's statement, so it's kind of like what you understood, you are paraphrasing it, but not just paraphrasing it, you're saying, oh, so I'm trying to think of an example. So if you went to Disney World this weekend, does that mean you had a good time, or was it just exhausting? You're kind of like trying to interpret what they mean by, hey, I went to Disney World this weekend. Checking out. So this is where you ask the patient to confirm something so you can better understand it. If they said something that is vague, you check it out. You say, wait, hold on. So was that was that something you expected, or things like that. Informing. So you're sharing objective information. This is kind of where you're telling the patient facts. We're open from 8 to 4. Those are the facts. Confronting. You're making the patient aware that the observation is not consistent with the words. So kind of back to the initial example that I said. The patient might come to you and say, oh, I'm feeling fine. And they're wincing and groaning. You say, I know you said that you're feeling fine, but actually it seems like you're in pain, or it seems like you're not okay. You're confronting the patient with the reality of what's going on. And finally, summarizing. If the patient tells you this big long story about how they had such a great experience at infusion 2 days ago, and you just say, well, I really hope that we are able to provide the same excellent care for you in radiation oncology. Kind of like that. All right. So the assessment. This is really the big chunk of what this chapter consists of. We're talking about the different breakdowns of different types of assessments. And we're going to start with general health, and then we're going to go down this line. So the general health assessment, this is kind of like where you do that interview, or the self-report, or the patient, does the self-report, and then either the nurse or the radiation oncologist do the interview. This is where you obtain that history and physical, this is where you obtain that history, which is basically medical information, nutritional information, social information, lifestyle information, and the impact of cancer on the patient's life. So if they're having pain and things like that. The physical assessment. So this is where the therapist, so actually, just to jump back a little bit. So the general health assessment, the therapist isn't very involved in this, because this is something that usually happens during consult. The physical assessment, we're talking now more about what's happening to this patient on a day-to-day, and this is where the therapist is much more involved. So we have to assess their daily and their daily what's going on with this patient physically, and where we might need to intervene. So we have things like nutritional assessments. So this can be done by the nurses on their weekly visits, the doctor by the weekly visits, or the therapists. So if we notice that a patient has come, it's happened to me, patients come and say, I haven't eaten in 2 days. I say, oh no, we need to do something about this, because even though you're supposed to see the doctor on Friday, it's only Tuesday. So let's figure this out together now. So sometimes, whatever it might be, I can't keep anything down, I'm very nauseous, or everything I eat, I end up going to the bathroom right away, whatever it might be. We have to monitor it, we have to report it, and we have to make the correct referrals if we're the first ones to notice it. So nutritional consequences of cancer. So here we're going to talk about bad things that can happen in terms of if the patient isn't following a healthy nutritional regimen. So anorexia is the loss of appetite, and it is a major cause of cancer. Cachexia. Cachexia is the main term that we want to discuss today in terms of nutritional consequences. Cachexia is a state of general ill health and malnutrition with early satiety. I've never been able to say that word. So it affects 1/2 to 2/3 of cancer patients. So what does this mean? Basically, the patient's body is like going into a malnutritive state And it's almost irreversible. There comes a point where it's irreversible, where they're losing all this muscle mass, and it doesn't matter if we try to intervene. Later in the later stages, there's just no coming back from it. The body just kind of starts to shut down. So it's a metabolic syndrome. It's the loss of muscle with or without the loss of fat mass. So the main feature is weight loss in adults or growth failure in children. It's different from starvation. It's different from age-related loss of muscle mass, depression, malabsorption, and hyperthyroidism. But it is associated with increased morbidity. So anorexia and taste alterations are two major causes of protein-calorie malnutrition, known as marasmus, and all those other wonderful words. So pain assessment. Pain is one of the most feared consequences of cancer. This is what kind of makes patients really, really scared when they hear they have a cancer diagnosis. All pain is real, regardless of the cause. So even if you can't figure out what is causing it, the pain is legitimate at all times. It is mostly caused by a combination of physiologic and psychogenic factors. So there are several purposes to the pain assessment. We have to determine the baseline for the treatment and the intervention. So if the patient comes with a level 8, we need to make sure that we're going to address that level 8 aggressively. If they have a level 0 of pain, then you're kind of going to say, okay, maybe the treatment can wait, 2 weeks. If you have a level 10, you're like, oh my gosh, this is an emergency. We need to start them today. Determine which intervention is best for the patient. Is it IMRT? Is it 3D? Can this patient wait a little bit longer in order to create a more conformal plan? Things like that. And then you're going to enable the evaluation of the intervention. So which one's going to be best? There are 6 dimensions to consider when assessing pain. Let me just turn the page on the book. So the 6 that your book talks about: the physiologic, so the organic cause of the pain; the sensory, this is where the pain intensity, the location, and the quality; the affective dimension, which is depression and anxiety. Affective, remember, associated to emotions. Sociocultural, so here we're looking at cultural background and family dynamics. And behavioral, pain-related behaviors such as medication intake and activity level. And cognitive, so the meaning of pain, the understanding, attitudes and beliefs, and the level of cognition. So when we're talking about the physiologic dimension, we're talking about the pain that's associated with direct tumor involvement, so it's directly associated to the tumor. So, this growth on my arm is causing pain on my shoulder, kind of like that. The pain associated with cancer therapy. Now we're not talking about the actual growth itself is bothering me, but all of these interventions with chemotherapy or the radiation therapy, it's causing pain in the area that's being treated. Pain unrelated to the tumor or its treatment, just other generalized pain that has nothing to do with us or the tumor itself. And then 2 factors related to the cause of pain. We're talking about the duration, which refers to whether pain is acute or chronic. Acute, short-term, new, basically. Chronic has been present for 3 months or longer. And then we're just going to disregard the pattern of pain, 3 separate patterns. All right, the sensory dimension. So this is talking about the pain location, intensity, and quality. So the location, where is the pain? They need to point to it. Sometimes in CT, we'll put a marker directly where the pain is, or the doctor will place the marker, and they'll make sure to include that area in the treatment field in order to use radiation to effectively treat this pain. The intensity. So how bad is this pain? And this is kind of where you're looking at the scales. With the faces or the numeric from 0 to 10, how bad is your pain, things like that. And quality, how it actually feels. So what type of pain is it? Is it shooting? Is it always? Is it constant? Does it come and go? Does it when you do a certain position? Things like that. All right, so the affective dimension. It has 2 separate subdimensions, which are the cognitive and the behavioral. So we're going to start talking about the affective. Overall, we're talking about anxiety and depression. We're talking about emotions. And those are the 2 most common factors that affect cancer patients. The cognitive dimension talks about the pain influences thought processes and or the way people view themselves. So a lot of people think that if they are able to take the pain, they're going to get through this treatment better. But that's not necessarily the truth. Or if they say, if I complain about this pain, it's going to make me look weak, things like that. It's all in their head, essentially. And behavioral, so factors such as physical exercise, time spent in bed, and ability to do chores have been used to measure the pain behavior. So this is kind of where you look at the KPS scale or the ECOG scale for performance status. So the KPS scale goes from 0 to 100, 0 meaning dead, and 100 meaning normal. This patient has no complaints, no evidence of disease. Halfway through the scale, so if you look at 50, considerable assistance and frequent medical care are required. So things like that. You start to go down, in number, depending on how you're able to carry out your daily chores or your daily activities or yourself. The ECOG scale, same thing. It goes from 0 to 5. 5 in this case is dead, and 0 is fully active. You're able to carry on all of your pre-disease activities without restriction. When people get cancer, all these interventions, all these treatments, it really affects a lot of aspects of their life. Sometimes they have to stop working. Sometimes they can't even walk. Sometimes they're so fatigued and so nauseous that they can barely stand. So your behavior is very much affected, and you need to be able to make this proper assessment to see how we can help this patient. This also has a lot to do with social work and making sure that the patient has all those outside external help to not just get them through the treatment, but to get them through the rest of their daily lives. The sociocultural dimension. So here we're talking about the sociocultural factors that influence pain are ethnic, cultural, demographic, spiritual. So all these things that include age, gender, and race. So the tools to assess pain must be simple, short, and relevant for the patient. And here we're talking about the scales. So here we go. The McGill Pain Questionnaire is used to measure pain in complex pain situations such as chronic cancer pain. It's used for research. The Brief Pain Inventory was initially developed for oncology patients and has been shown to have reliability and validity. It's easy to use. It requires only selection of values from 1 to 10 on most questions and can be completed. So it includes measurements of pain intensity, a diagram for location of painful areas, functional assessment, and questions on medication effectiveness. So this is kind of like when you go to your doctor and it has a little drawing and it's like, oh, can you point out where your pain is, and you draw it in or you put an X. So if you're aware of your personal beliefs, of the personal beliefs of the patient, and the personal beliefs about pain, their biases about pain, you are able to communicate, you're able to observe, it's going to make you a much better or a much more holistic healthcare provider. We need to not just address pain as like in a medical perspective. We need to address it in a holistic perspective, meaning if this is a patient that comes from a culture where pain is viewed as weakness, then we cannot address it as like, oh my God, you're in so much pain, we need to help you, because the patient might feel offended, and we don't want to do that. So we kind of have to take a step back and see how we address this with the patient effectively so that they feel like they're being supported in the situation and not attacked. All right, blood assessment. I love this part because it's super straightforward. So hematologic changes in cancer patients are critical for ongoing assessments because hematopoietic tissue exhibits a rapid rate of cellular proliferation. All that big sentence is saying is that blood affects really quickly, or the blood responds to radiation very, very quickly because it's constantly multiplying or constantly proliferating, So the cells are constantly multiplying, the cells are constantly dividing. So when they're getting treatment for radiation, you see their reaction very quickly. So it's very important that you do weekly assessments in patients' blood counts and things like that, depending on the area that we're treating and how large the area is, to make sure that we're staying on top of changes in their blood counts and obviously the side effects that come with that. So myelosuppression is a reduction in bone marrow function. And the changes that occur can be anemia, which is a reduction in red blood cells, leukopenia, which is a decrease in white blood cells, and thrombocytopenia, which is a reduction in platelets. Oh, I just went over these. All right, the psychosocial assessment. So here's where we start talking about quality of life. Quality of life is the broad assessment of the combined effect of disease and treatment and the trade-off between the two. So yeah, it's great that we can attack certain cancers aggressively and that we can say, oh my God, we can get rid of this cancer, whole brain therapy for everybody. Wait a second. If we treat everybody whole brain therapy, with a very aggressive dose, then their quality of life is going to diminish. This patient might not be able to walk. This patient might lose their ability to eat by themselves, to communicate, to think. So what's the trade-off here? Where's the benefit here? Is this really what's going to be best for this patient? Their quality of life is a subjective sense of well-being derived from the personal experience of life as a whole. So if this patient is going to be experiencing a much more difficult day-to-day because of the radiation therapy treatment, then maybe it's important for them to evaluate if this treatment is worth it. Especially when the prognosis doesn't look like the patient is going to survive very, very long. Then you have to kind of sit down and evaluate, like, is this really worth it? Is it okay to completely, diminish their ability to take on the day-to-day of their lives for this treatment? Or is it better to kind of just let them live with a great quality of life, but obviously the disease is still growing? Things to, scale or balance. The assessment should include physical, psychological, and of course social factors. So the coping strategies. So effective responses that occur most commonly among patients are the anxiety and depression. Anxiety is an individual responding to a perceived threat effectively at an emotional level with an increased level of arousal. Vague, unpleasant, uneasy feelings. That's what anxiety means. So the measuring tool is the state trait anxiety inventory. And then we have the family members. So these must take on a new role, new self-care skills, ways of communicating with each other, friends, and the healthcare team. When one person gets cancer, it's not just the patient. You're talking about the whole family has to adopt this new role of, oh my God, my mother now has cancer, or my husband now has cancer, whatever it might be. You become a sort of a victim of that cancer as well. And you have to address how the family is tolerating it. Some individuals are stronger than others emotionally, in terms of sometimes the patient's like, oh, I'm fine, but their significant other is having a very difficult time processing this. And us as therapists, we have to make sure that the support system around this patient is able to tolerate what this treatment means and tolerate what this means for the patient, because they need to feel the support not just when they come into clinic, but also when they walk out of clinic and when they walk into the hands of their family members or their caregivers. The cultural assessment. So here we're looking at the cultural beliefs, the values, and the practices that the individuals have and the communities that they form. So when you're culturally sensitive, you're caring for the whole patient. You're taking their culture into consideration, even though it might be different from what you're used to, even though it might not be something that you're an expert in. If you show sensitivity towards that, if you're able to say, hey, I don't really know much about your culture, but it seems that this is important to you. Let me know how I can help you achieve that. It's going to make you much more better, or much better well-rounded caregiver, or provider, I should say. So we're looking at values, beliefs, and customs, or values, beliefs, and I know I wrote it down. Where is it? Values, beliefs, and practices. So the values are the most difficult and are established in early childhood through an unconscious process of socialization. Beliefs include knowledge, opinions, and faith about life built on their values, and their customs are the result of values and beliefs that are most observable, or their practices, basically, what they do. And finally, the spiritual assessment. So here we're talking about the man's inner resources, especially his ultimate concern, the basic value around which all of the values are focused, the central philosophy of life. So here we're talking about giving meaning to life, to death, and to the illness. The spiritual assessment. So 4 areas related to meaning and the spirituality in the patient's life. So how do they view God or a certain deity? Where do they get their hope and their strength? the significance of their religious practice. So how high do they value this in their life? Do they have certain religious practices that come before everything else, or it's just not something that forms part of their day-to-day life? And their relationship between their spiritual beliefs and their state of the health. Do they, identifying how important this spirituality is to them is going to make you a better provider, because if it is very important to them and you can somehow include it in their care, they're going to feel like they're in much better hands. And if you ignore it and it's very important to them, they're going to feel like you're not supporting them. Oncology healthcare providers should do the following. So assist patients to experience their own spirituality. You're not here to impose anything on the patient, but it's meant to encourage the patient to experience their own spirituality. Listen carefully to the patient's expression of belief. So you have to do a lot of listening. If possible, provide an appropriate environment and quiet time for reflection and contemplation, and assist the patient in finding resources for spiritual fulfillment. I currently work in a faith-based hospital, and it is very common to pray with patients when they ask us to pray with them. So I love that part of my job personally. And if you ever find yourself working in a hospital that is faith-based, the spiritual side of the treatment is actually incredibly important. So hope is a key concept and an essential ingredient in the religious and spiritual aspects of care, as well as a major component in the healing process. Hope is what allows people to keep going and gives them the strength to continue on with their treatment. So special cases, we're going to talk about 3 special cases. Children. So when you treat children, you have to be able to identify the areas of depression, withdrawal, anxiety, delinquency, achievement, family relationships, and development. They are not like treating regular average adults. They're growing. They tend to be kind of lost in their innocence and in their youth, which is a very wonderful thing. But the side effect of it is, if this child, moves on to adulthood after having cancer as a child, their views of life and their views of the hospital system and their views of how the cards are dealt and all that, it can be very jaded. Adolescents, when you treat adolescents, these are a little bit, in my opinion, these are a little bit harder to treat, because they're very much aware of the situation. They kind of know what cancer means. When it's a child, they don't really know what cancer means. They're not interested in that. They want to watch their Disney movie and move on. Adolescents, they've heard the term, they've probably seen family members at this point, and it kind of clicks a little bit more for them, so it's a scarier time. They're also much more worried about their self-esteem. They hate not having, or not all of them, but a lot of them hate losing their hair. They hate that they're losing a lot of body weight, and here their classmates are, using all of these physical aspects to show, their development and their growth, and they just kind of feel stunted. The elderly, so you have to be able to understand where the status is what the status is on this elder patient. So are they able to hear you well? Can they see you well? Are they understanding what you're saying? Sometimes they have dementia, so you have to be very creative in the way that you assess them, and very creative in the way that you treat them, and you deal with these difficulties. So assessment for specific and non-specific events. So radiation therapists assess the treatment side effects on a daily basis. Every single day, we look at the patient and we ask them, how are you doing? How are you tolerating the side effects? Specific side effects are site-specific. Remember, radiation is a local treatment. These should be looked at the entire course of the treatment. The side effects include skin reaction, hair loss, mouth changes, nausea, vomiting, diarrhea, cystitis, and pain. So skin reactions, we're looking at faint erythema, which is reddening of the skin. It usually happens at 16 gray. Erythema, again, reddening of the skin. You have a picture of it in your book. Right in the beginning of the chapter, if I could get to the page 47. Erythema, 20 to 30 gray. Dry desquamation, so this is kind of when your skin starts to peel, kind of like when you go out in the sun and you peel. Dry desquamation, 30 to 40 gray. And the most severe is moist desquamation. So this is peeling, but with kind of like a moist, it's kind of wet, and you can tell like the skin is kind of, I don't know how to say it, it's kind of releasing fluid. This usually happens at doses greater than 40 gray. Epilation or alopecia. So alopecia means hair loss. It occurs around 15 to 20 gray. Scalp irritation can occur. So obviously, patients being treated to the brain, they lose their hair. Patients should avoid frequent shampooing, blow dryers, hairsprays, gels, and other hair products. We never ask patients to directly use blades to like shave their hair. We use the little machine. Be very gentle with your skin. It's like a sunburn. Think of it that way. You wouldn't, get waxed on the skin that you just got a sunburn in, and you wouldn't use your razor blade to put it right skin to skin. Mouth changes. So these all occur between 20 and 30 gray. You assess the presence of stomatitis, xerostomia. Xerostomia is dry mouth. Mucositis, so like an inflammation of the mucus, and taste changes. And the doses that cause pharyngitis are 20 to 30 gray, laryngitis is 40 gray, and esophagitis is 20 to 30 gray. Remember that itis means inflammation, so any word that ends in itis means inflammation of, and then that root word. So esophagitis, inflammation of the esophagus, 20 to 30 gray. Nausea and vomiting. So what advice are you going to give to patients that are having nausea and vomiting? You need to ask them, how are you eating? What are you eating? You need to say, do you have antiemetic medications? Are you eating at certain times of the day? And should you be eating at different times of the day? Things like that. Diarrhea and colic occurs at 20 to 50 gray. You have to assess the bowel function. You have to give them advice on their dietary information. If not, you can always refer them to the dietitian. Antispasmodic medications, so Imodium if you need it, and instruct the patient in perianal care, so keep the area clean. Cystitis is referring to your bladder, so inflammation of the bladder. 30 to 40 gray, you're assessing the bladder function. You have to check for urinary retention, so are you able to pee or not? And then hematuria, are you seeing blood in the urine? Again, using antispasmodic medications as prescribed, and you have to monitor for bladder infections. This is very common in GYN patients. They are very prone to getting bladder infections, UTIs, so a lot of them do get urine tested, or they get their urine tested like on a weekly basis. Pain. So it's associated with inflammatory reactions at varying doses. You have to assess the location and the intensity and instruct the patient on the importance of taking prescribed medications. Nobody is expecting anybody to be a superhero here. This is what I tell patients all the time. No one expects you to be a superhero. We want you to get through this treatment, and we want you to get through this treatment comfortably. We don't want you to be wincing in pain the entire 20 minutes that you're lying on this table. Please take your pain meds. Please take your Tylenol. Please take your ibuprofen, whatever your doctor said is safe for you. Non-specific side effects. So here we're looking at skin pallor, weight loss, fatigue, and sleep. So these aren't localized to one area. Here we're talking about just in general. The weekly complete blood counts can be done, so you're looking at the CBC to see if it's related to probably anemia. You're also monitoring the weight once a week. Patients get weighed every single time they see the doctor once a week. You're assessing their energy level, how are they feeling. You're checking their nutrition intake and their sleep patterns as well. Additional considerations related to side effects. So side effects occur earlier if the patient is having or has had chemotherapy. So concurrent treatments, those patients are much more likely to show side effects much quicker. Side effects may be lessened if proper teaching is given on an appropriate level. So what this means is the skin erythema, we give them instructions on what kind of lotions they can and cannot use, whether they can shave or they can't shave, things like that, in order to help prevent the skin from becoming even more sensitive to radiation. Also, when can they use these lotions and how often should they put them on? All of these things work alongside the radiation, and if they actually put lotion before their treatment, you're actually going to make the reaction worse. So we always need to make sure that we're on top of that with the patient and that we're educating them properly. Involving family and education of radiation will help reduce problems associated with side effects. So sometimes you talk to the patient and they are so overwhelmed with all the information that they received that whatever you say doesn't go anywhere. It goes in one ear and out the other. If you involve their family or their caregivers in what kind of meals they should eat and how often, and what are the requirements for their treatment, if they need to have a full bladder, make sure that they stay hydrated, they're also going to help keep this patient support this patient through this treatment outside of the clinic. So all the other time that they're not getting treated for. And that's it. Thank you guys so much. I will see you guys for the live session this week and keep up the good work. We're almost there. Bye.